So welcome everybody. Thank you for joining this morning or this evening, wherever you are. We hope you are well. My name is Karen Eggleston and I am Director of the Asia Health Policy Program at Stanford University. And I'm delighted to welcome you to our colloquium this evening or this morning, wherever you are. We have a distinguished set of panelists today, and before I introduce them, I will talk briefly about our upcoming webinars. We have in our series on public and private roles in health, medicine, and longevity, several events coming up in January in winter quarter, starting with the 20th on public-private collaborations and non-government organizations, and our own postdoctoral fellow, Dr. Radhika Jain, on January 28th, and a keynote on conceptual thinking from Nobel laureate Oliver Hart on February 10th. We hope you'll be able to join us for some or all of those. As always, they're free and open to everybody around the world. Today, we're delighted to have with us a distinguished panel of speakers as part of a collaboration on net value of chronic disease control, talking about the important issue of chronic disease and its prevention and management during the current pandemic. We have speakers that come across from multiple different health systems of the region that are part of our collaborating network, and we're very thankful that they've joined us today. We have Professor Nikhil Tandon from the All India Institute of Medical Sciences. To save time for the speakers, I will not be giving an extensive introduction about each of them, but they have a distinguished record of research in all of these areas. Professor Tandon will be joined by Dr. Kavita Singh of the Public Health Foundation of India. After that, we have Professor Lijing Yan of Kunshan University and Dr. Jianchao Quan of University of Hong Kong. And then Dr. Daejung Kim of the Korea Institute for Health and Social Affairs. And finally, Professor Piya Hanvoravongchai and Dr. Wasin Laohavinij from Chulalongkorn University in Thailand. To set some background for their discussion of recently collected empirical data, I'll share just a few figures about the current pandemic and the restrictions put in place to control it. On one axis, you have confirmed COVID-19 cases per 10,000 population. And that is the dark line in each case. And the red line is the Oxford measure of restrictions to control its spread. So here in India, you can see that axis. If we were going to put it for the US, it would be much higher, but we put it on a lower axis so that we could show what's happening relatively in our economies in Asia. That is China, where the restrictions were put in place earlier and have come down recently. In South Korea, similarly, put in place in the spring and come down more recently. And in Thailand, where again, there's very few cases per capita, but significant restrictions put in place. And this is one of the issues that we'll explore, the impact of the pandemic more broadly, economically and socially, beyond treating those specifically with the disease. So with that as background, I'll turn it over to my distinguished colleagues from Asia. And first to talk about the data from India. Professor Tandon, over to you.
Good evening or good morning to all the attendees in this webinar. So the data from India will be related to a mixed method study which we recently conducted to look at the health, psychosocial and economic impacts of COVID-19 on people with chronic conditions. And this has two parts, a quantitative part, which I shall discuss, and then my colleague, Dr. Kavita Singh, will take you through information on the qualitative component of this particular study. Could I have the next slide, please? The survey essentially was prompted by the pandemic, which, as you know, has struck us over the last whole year. There are very limited data documenting the impacts of pandemics from low and middle income countries such as India. But I think for this particular survey, the important thing to point out was that towards the end of March 2020, at a relatively short notice, the government of India ordered a nationwide lockdown, which was fairly extreme in terms of an total abrogation of all public transport or travel between states and cities, in terms of what markets could be open, who would be allowed on the road, and therefore there was a significant restriction in travel except for services which are considered to be essential. Over a period of time, we've now had 4 phases of unlocking. There are now some restrictions still in place, but they're primarily extended to what are called containment zones, which are small pockets with significant amount of disease. The objectives of this survey were to assess the impacts of COVID-19 and more specifically, the related mobility restrictions on access to healthcare, health status, and self-care behaviors, specifically in individuals with known chronic disease, to assess the impact of the pandemic and these restrictions on employment and household income, and then also do a comparison between rural and urban communities to see whether they were differentially impacted because of the disease and the restrictions. So we took the advantage of having pre-existing ongoing large longitudinal cohorts. We looked at a single point of data collection out here, which was cross-sectional. The region was stratified into 4 states, and there were 2 urban sampling areas and 2 rural sampling areas. For reasons of limited mobility and the fact that there were concerns about in-person contacts, a telephone survey was conducted in adults with known prior chronic conditions, as had been ascertained in previous rounds of the survey. And the conditions that we looked for diabetes, hypertension, heart disease, stroke, and chronic kidney disease. Data were collected for this study between the end of July till the middle of September in 4 sites, Delhi and Chennai, which are in the north and south of the country. These are primarily urban conglomerations, and Sonipat in Haryana and in Vizag in south central India, which were predominantly rural communities. So we contacted about 2,300 individuals who were known with chronic disease in these 4 sites. 1,734 responded, a response rate of about 74%, a mean age of 58 years. Half of the respondents were men. And this is what I will share with you in terms of the primary issues that we looked at. And if I could have the clicks on the screen to save time, there are 3 clicks we brought on. The questions we asked were COVID-19 cases in the locality. And as you can see, about 3/4 of the urban respondents could actually identify known cases in the locality, as opposed to just about 3 out of 5 in the rural areas. Fear and stigma related to COVID-19 was much more seen in rural areas. Nearly 9 out of every 10 responded, as opposed to about half of those in urban areas. Difficulty in coping with stress was equivalent between the rural and urban communities. Experiencing an acute medical illness was seen in about 1 out of every 15 or 16 participants in the urban areas and 1 out of every 7 in the rural areas. So there was this differential exposure to an acute medical illness. Difficulty in accessing healthcare facilities was fairly uniform. 3 out of every 4 urban participants and nearly every single rural participant referred to a difficulty in accessing healthcare facilities. Could you just click the buttons a couple of times, please? Okay, it seems we've lost, can we go back? I'm sorry about this. Okay, difficulty in accessing medicines was a larger problem seen in the rural areas, with again, nearly 2 out of every 5 having this problem, as opposed to about 10% of those in urban areas. We then asked them about worsening of diabetes and hypertension symptoms, and this was again clearly there, but a relatively smaller proportion in the urban participants, as opposed to about 20% of the rural participants. And this is in comparison, when we look at this, we compared people with diabetes with those without diabetes, and people with hypertension and those without hypertension. There was a definite decline in the functioning of the local health facilities, and about 60 to 70% of the respondents said that the local health facilities were either functioning at a low level of functionality, or were not functioning at all because of staff redeployment, or even closure of some health facilities and deployment of staff to what were called COVID areas. Treatment satisfaction again declined. Interestingly, this was a lesser decline in rural areas, maybe because the background treatment satisfaction in rural areas was low to start with. We looked at fruit and vegetable intake as an important marker for healthy food habits. And again, because of restrictions in travel, because of restrictions in transport and transport of goods, there was quite a dramatic reduction in fruit and vegetable intake, especially in the rural areas. A loss of job in nearly 1 out of 3 people, and a loss of income in about 60% of all participants. Now, these are two very important parts, as you will see during the course of the rest of the presentation, which contributed to these issues. So what were the correlates of difficulty in accessing medication? Yeah, there are a couple of more clicks on this one, please. Thank you. We looked at multiple regressions out here. We compared different parameters, including age, gender, whether it was rural or urban, the degree of education, the quantum of income, the presence of underlying disease, and whether or not they'd received financial support from the government and experienced the loss of job, a loss of income. As you can see, difficulty in accessing medicine was much more profound in rural areas, number one. That if they had an existing chronic condition like diabetes and hypertension, which really necessitated the requirement of accessing medicine, this again was significantly impacted. So people with chronic conditions had difficulty in getting their regular supply. This was mitigated to some extent by the financial support offered by the government, but was not uniformly taken care of. Next, please. Now, what are the correlates of worsening diabetes or hypertension symptoms? Again, we looked at a whole range of parameters, including demographic variables, obviously the existing chronic conditions, the presence of a general anxiety disorder, which have been sort of triggered or precipitated by COVID-19, the ability to do physical activity, the consumption of fruit and vegetables, and as I already mentioned in the previous slides, issues about access of medication, receipt of financial support, and loss of job or loss of income. And again, as you can see, obviously having an underlying chronic condition would be the primary reason for a worsening of those conditions, because that was pertinent only to that subgroup. But difficulty in accessing medication, experiencing a loss of job and loss of income were very, very important correlates of worsening diabetes or hypertension symptoms. And you saw from the earlier slides that difficulty in access of medication, loss of job and loss of income were a significant issue and were more profound in rural areas. Receiving financial support again did mitigate this to an extent, but could not overcome the entire problem which was created by the pandemic and or the mobility restrictions consequent to the pandemic. Next, please. And therefore, the implications of survey results, and this is my last slide, I think the three important implications which we could gather were that there were clearly unintended consequences on healthcare access, because facilities were being utilized for other purposes. People could not access facilities, and the same staff which were otherwise supposed to provide care for chronic conditions were being utilized for other purposes. There was a definite impact on the psychosocial and economic status, which impacted on the ability of people to look after themselves. This, however, does open new opportunities to look at strategies to revolutionize patients' access to treatment, whether this could be addition of home delivery of medicines, whether this could be home monitoring devices, or in India, the big impact which happened, which has now started getting more and more established, was the fact that the government actually notified what are called the telemedicine practice guidelines. Previously, telemedicine practice used to happen in an informal fashion, but with the release of the telemedicine practice guidelines, this is now an official government regulation which clearly stipulates what are the sort of telemedicine which can be practiced, who are the people who can interact, what are the sort of visits, either first or follow-up, and what are the sort of medication which can be prescribed. And I think that has been a substantive gain which we've had, which was actually precipitated because of this particular pandemic. I'll stop here and hand over the presentation to Kavita, who will take you through the qualitative study. Thank you so much.
Thank you, Professor Tandon, and good morning and good evening to everyone from wherever you are attending this webinar. So I'm going to take a dive into the qualitative study results from this mixed method study that we did in India to understand the impact of pandemic on people with chronic conditions. So the specific objective of the qualitative study was to describe the challenges posed by the COVID-19 pandemic in people who are living with chronic conditions and their mitigation. So for this study, we invited 40 patients with chronic conditions, and we purposefully selected a diverse representative sample across age group, across gender, across the 4 sites, urban and rural areas, and those with comorbidities, and also those who have had been diagnosed with COVID-19 during the lockdown period. So these interviews were conducted in their local language over phone, and then these were audio recorded and transcribed and translated. And then we coded these interviews using the MaxQDA software, which is a qualitative data analysis software. We used thematic analysis using interpretative approach and deductive logic to arrive at the themes coming from this analysis. We also used non-illustrative quotes to support our qualitative findings. So this analysis identified a number of challenges that patients experienced during the lockdown. And here we categorize them into 5 major themes. The first major theme that came out from this analysis is the financial difficulties that patients faced, and most participants experienced difficulties in either continuing their business or they lost their jobs. As you can see in patients' own words, how they described the impact. The patient says, this is a patient from a rural community from Visakhapatnam. The impact was that there were a lot of problems. We took the ration distributed by the government. We consumed that. There were a few things we sold, 1 or 2 things that were at home. And my son drives a rickshaw and my husband stays at home. We are old. It impacted him. He was out of work for 3 months. Then another patient described the difficulty in getting back to work due to the lack of transportation. In patient's own word, patient stated that we face difficulties at home because I'm into driving. I'm a driver. Before lockdown, I went home for some work. And because of lockdown, I had to stay at home for 2.5 months. I, my wife, and children are jobless since then. There was no possibility of doing any work or going anywhere. We had a lot of trouble at that time. This is an urban participant from Delhi. Then a number of patients also face difficulties in accessing inpatient services and access to important treatment, as described by an urban patient from Visakhapatnam. I was not keeping well and none of the hospitals were taking any admission. They said that due to COVID, beds are not available. If you are ready to sleep on the ground, then we will take your admission. Lastly, a number of patients with diabetes, hypertension, and other chronic conditions, they delayed their testing of blood sugars or other regular tests or visit to the doctor due to the fear and anxiety associated with the COVID-19 pandemic. As described by one patient, that I was scared that I may not have this COVID infection, but because of someone else, I may get infected. We have doubt to go to the hospital, to the doctor, and I didn't want to get infected by this, as described by an urban participant from Delhi. So when we asked them about the lessons that they learned from this pandemic and the restrictions that were imposed to reduce the spread of infection and the preventive measures that they followed, most participants were well informed of preventive measures like wearing masks, social distancing, or washing hands. Particularly participants with diabetes and hypertension, they were mostly aware of the elevated risk of poor outcomes if they get infected with SARS-CoV-2, and many fear to go out for a walk or other regular exercise, which also impacted their self-care habits. Very few participants reported use of teleconsultations with doctors. And in general, to sum up about the preventive measures, these participants were aware, and one of the participants from Delhi quoted that we have to be careful from the corona and we have to be safe from this. That's the only medicine now. So just to conclude, this survey provides the first insights into the effect or the impact of pandemic, and we have seen that the pandemic had unforeseen adverse impacts on the health access to treatment, achievement of care goals, and also in employment. Particularly rural participants were disproportionately affected, as we saw that they had poor treatment to access, very low treatment satisfaction rate. Also, they reduced their fruits and vegetable consumption compared to pre-lockdown period. Also, pandemic impacts extends beyond healthcare access and achievement of care goals. As we saw, the pandemic impacted household income, their livelihood, their coping skills, where a lot of patients face difficulties in coping with the pandemic, and it also affected their interpersonal relations. Lastly, I would like to mention that this pandemic exposed several management difficulties in the health system, but it also provides us an opportunity to close these gaps with healthcare innovations in the new post-COVID India. I think I would stop there, and I would like to acknowledge all the senior investigators for their leadership and guidance in designing this study and in interpreting the results. Particularly Dr. Prabhakaran from Public Health Foundation of India, Dr. Mohan from Madras Diabetes Research Foundation, Dr. Venkat Narayan and Dr. Mohammed Ali from Emory University, and Professor Eggleston from Stanford. Thank you very much.
And if there are questions of clarification in the Q&A, we could take any of those now. Not seeing them, we'll come back. Please put your questions in the Q&A as we go, and we'll come back for discussion at the end of all of the presentations. Continuing now, Professor Yan.
Thank you, Karen. It's good to be in this network. I'd like to show you very preliminary results from our study showed the impacts of COVID-19 on diabetes and e-health. And I like to acknowledge my team members. Next, please. Karen has provided a good overall background for COVID-19, the governmental control measures versus the cases. Most of you are familiar with China's situation. You can see from the graph on the left, which is red, you can see the cumulative number of cases increased sharply in earlier this year and stabilized for the most part. And the green one was the cumulative recoveries. And so this is the trend of our pandemic. It's marked by very high governmental control measures and stabilized situation since April. But there were a few episodes of small outbreaks in a few cities, such as Beijing, Qingdao, and Xinjiang, and some imported cases. So our country overall, even though many measures were relaxed, but for people who are tackling this pandemic, they were still on heightened effort, awareness and effort. Next slide, please. Yes, for our particular study, we based our study on COVID-19 on a cohort we had from last year. So this is a study on urban NCD management in China, including people with diabetes and or hypertension. We decided to work on people with diabetes only. And we had 330 people in this cohort with data collected from last summer from 10 communities in 2 cities. These 2 cities are not far from Shanghai. One is Kunshan. This is where our university is located. The other is Taicang. And both cities are part of the Suzhou municipality. And we conducted our survey on iCode in August of 2020, and this was quite a few months after the outbreak in China. And the epicenter of China's COVID-19 was in Wuhan, as you know, and the province of Hubei, where Wuhan is the capital, and mostly nearby provinces. So for Jiangsu, we had, excuse me, for the whole province of Jiangsu, there were 697 cases throughout, and Kunshan City had a total of 19 cases, all back in February, March, and Taicang had 3 cases only. Back then, we had soft lockdowns as opposed to the hard lockdown there in Wuhan. So people were encouraged to stay at home, but many services, including health services, were still available, especially community-based healthcare services providing essential care and medicine to diabetes patients. Yeah, I show in this graph the characteristics of our population, which included 309 patients with diabetes with a very high response rate. Our patients were, mean age was 63 years old, ranging from 34 to 85, about half being women, and most of them had health insurance and did not have problem access health facilities in the pandemic. And in terms of accessibility to internet, this is website-based, not cell phone-based access, or mostly computer. About 60% did not have it for our population. And what's shown on the right-hand side was the distribution of family income, monthly income. And most of our participants had between 5,000 to 15,000 renminbi per month for their family. And we didn't have any COVID-19 case in our 309 participants. And in this last slide, what's shown are two findings. One of our main results, the blue ones showed economic loss and the impact on diabetes. So the top left graph showed that 61% reported no income loss, but 12% reported great income loss, 21% average income loss, and about 6% small income loss. And the degree of loss was assessed by self-report. And also you can see that 16.5% of our participants reported that they had problem with diabetes management during the pandemic because of economic related issues. And in terms of e-health, the results were even a bit surprising to me because our area was mostly urban, even though some residents were rural, but they lived in urban areas. But for this older patient population of diabetic patients, they didn't have, they have very low use of e-health, whether before or during. So before it was only 4.8% using e-health defined as APP or any other services on the cell phone or telemedicine with their health service provider, etc. So probably a non-significant increase during the pandemic, possibly due to the fact that we didn't have COVID-19 and then services were mostly available. This is all I have prepared for the 5 minutes. Thank you.
Thank you very much, Professor Yan. I'll pause there for a minute if there were any questions of clarification that people wanted answered. If not, we'll come back discussion at the end. So next on to our colleagues from Hong Kong. Charles, over to you.
Hi. Hear me? Okay. So yeah, talking from Hong Kong. So we also conducted some cross-sectional telephone surveys that you've heard some of the other group earlier do. So we started ours in May from October, and we tried to capture 18-year-old adults resident in Hong Kong during this time. So we collected their social demographic information and their health reported status. So in our sample, about 5% had diabetes and about 12% had hypertension. So in this figure, you can see in the gray bars are the number of cases in Hong Kong. So we had a relatively low number of cases. So this is the total number of cases per 7 million population per day. So at our peak, we had about 150 cases. So we really captured the survey times before and after the third wave in Hong Kong. Next slide. Okay, so we ran also regression models to look at people who had worsening chronic conditions, and about 7% of the people with chronic disease did get worse. So in our sample, you can see that particularly those with kidney disease, quite significantly worse. And again, with depression. So I think many people who've gone through the COVID lockdowns have experienced anxiety and depression associated with that. And that's what we've captured as well. In terms of reduced access to healthcare, because the number of cases were relatively low in Hong Kong, we haven't seen anything too significant regards to the different chronic diseases here. And with avoidance to healthcare facilities, again, nothing too significant. We had quite well controlled and relatively short wave, and most things are relatively back to normal. So although not significant here, about half of our sample of people with chronic disease did avoid healthcare facilities, and we're capturing more surveys, and maybe we'll be able to see some significant variables there. That's all we have.
Thank you very much. Pause here a minute for any clarifications, but not seeing any. We'll move ahead. So on to Dr. Daejung Kim from Korea. Daejung, are you there?
Oh, sorry, I was make a mute. I'm very pleased to participate in this webinar, and I'm sorry that we are still collecting the data for the study. And we are surveying now 500 diabetes patients and 500 hypertension patients, and we are surveying on their accessibility to the care and the effect of COVID-19 on the health. In this webinar, I'd like to share the thought on the COVID-19 mitigators in Korea. In Korea, we had the first confirmed cases on the January 14th, and after that, we had in February we have the peak in the confirmed cases, and the second wave was occurred in the August. And in the public health point of view, we believe that in combating the COVID-19, I would like to say that masks was effective, and of course, testing and tracing and treatment of the confirmed cases was important, and the telemedicine also could have give the benefits on the mitigation. Next slide. In Korea, the mask, if you look at the upper right side of the slides, the mask price was the purple line is a mask price. There's 4 kinds of masks, and the mask price was decreased from, for example, 4,500 won to 913 won. That means the mask production in the beginning of the COVID-19, mask was in short, but government quickly take the measures to the emergency supply, and their production was increased quite about 5 times during the pandemic period, and the mask price was stabilized, and now almost everybody takes masks when they go out. And we believe that after the COVID-19, I think we have to calculate what was the health benefits of the masks, but that could have a good important portion in the mitigation. On top of that, I would like to say that testing, of course, tracing and the treatment for the confirmed cases in Korea was important. In particular, drive-through testing was applied in Korea first, and that measures was also still in effect, and it could have it gives the benefits, I think, to the COVID-19 combating. And of course, telemedicine, I think, important. When you look at the one study from the USA, total visits in primary care, if you look at in 2018 and 19 and 20, was in 2020, it is decreased compared to the 2018 and 2019 because of COVID-19, I think. But when we look at the portion, please, the previous slides, when we look at telemedicine, the share is increased from 1% to 35% in USA. So because of fear of the infection, they went to they used the telemedicine, but also to combat the COVID-19. The telemedicine could have been a good tool for the mitigation. And but unfortunately, in Korea, between the doctor and patient, the telemedicine is impossible under the current law, because of the medical association. Because of the legal responsibility due to the misdiagnosis and lack of verification of telemedicine effects, and the focus of large hospitals and the bankruptcy of the primary care institutions was the main reason for the opposition. But next slide. But the government and the Korean people, they believe that the telemedicine could be a good measures. And during this pandemic period, the government temporarily allowed the phone consultation and the prescription and the telemedicine to overseas Koreans. So we believe that that technology can be used widely when times go on, but still we have to consider the legal institutions, legal background in Korea. On top of the domestic telemedicine, cross-border telemedicine also will be widely spread when the legal factors and the infrastructure is in place, and the cultural and linguistic factors are permitted. And this technology could be a new tool in medical environment. So I want to. It should be if we had the data and the results on the accessibility of the care and the health benefits, health effect of the diabetes and the hypertension patients, that could be a good for the webinar. But I'm sorry that we couldn't share the result yet. Thank you very much.
Thank you very much, Dr. Kim. Yes, it's ongoing research with many of the teams. Unfortunately, Vietnam also is not able to join today, but we're delighted to have our final team from Thailand presenting. Dr. Piya, over to you.
Thank you, Professor Karen Johnston. On behalf of the Thailand team, we appreciate the opportunity to share our preliminary findings. I'll just give an introduction to the situation. Basically, we have had a pretty relatively lucky situation here, as we have only about 3,000 to 4,000 cases cumulatively so far. And the government response seems to be very intense during the first few months in April and May. The challenge to NCD and diabetes care were not only about the COVID though, because there were a lot of adjustment and this adaptation, including the change in the way that health services provided, reduction in the number of outpatient quotas for patients, and also the change in the patterns of follow-up that extend the number of months that people come back to follow up. So Dr. Wasin, who's leading this work, will share some preliminary findings from our analysis of the data.
Thank you, Professor Piya. So our data is the monthly data from year 2017 to 2020 from our Ministry of Public Health Data Center reporting system. First, I would like to start with the number of monthly outpatient visits. As you can see on the blue line in the graph, is the number of monthly outpatient visit average from year 2017 to 2019. And the back line is indicate the data from year 2020. The red arrow in the graph is when we first have the large community spreading, which start in the first and second week of March, and other policies and intervention from the government start later on during the third and the fourth week. Compared with 3-year average of outpatient visits, we see around 19% drop of the outpatient visit utilization in April, and the drop increased larger to 25% in May. The recovery of the outpatient utilization start in June, and the recovery period is better in July and August, which is around 12% drop and 10% drop, but it still didn't increase back to the previous year outpatient utilization. Next, we would like to show the data on our number monthly inpatient visits. As you can see from the graph, the number of monthly inpatient visits is very similar compared to the outpatient visit, but we see a faster recovery starting in May compared with the outpatient visit, which is starting in June. Furthermore, we also analyzed the severity defined as number of days per admission, and we didn't see any increases of the severity between pre and post-COVID period. When we look into the diabetes and hypertension screening and diagnosis, we didn't see any significant changes in the diabetes and hypertension screening coverage compared between the previous year and year 2020. Actually, in year 2020, we see a little bit increase, around 2 to 3% coverage more compared to the previous year. This because majority of the screening were done during winter and spring, which is in October 2019 to around February and March 2020, and most of the screening were done before our first large community spreading. However, when we look into the number of newly diagnosed diabetes and hypertensive patients during the same period, we see there is a drop similar to the outpatient visit patterns, which in hypertensive patients, there is around 20 and 30% drop in April and May, and in the diabetes patient group, there is around 20% drop during the same period. And also, we also see the recovery of the number of newly diagnosed diabetes and hypertensive patients in June, which in diabetes group has a faster recovery compared to the hypertensive group. This drop may indicate a delay in access to care for confirming diagnosis after receiving abnormal screening results due to COVID. Next, one of the complications of the diabetes and hypertension is stroke, which we choose as a proxy of this preliminary result. As you can see on the graph on the left upper hand side, in year 2020, the number of newly diagnosed stroke patients is around 10% lower compared to the previous 3-year average, which is in the blue line. However, after the COVID pandemic on our first community spreading, we see an additional 17% drop in number of newly diagnosed stroke patients compared between pre and post COVID in the same fiscal year. Furthermore, we also look into the stroke mortality rate between the previous year and year 2020, but we didn't see any significant difference, which there is around 5.8% and 5.3% in stroke mortality rate between the previous year and year 2020. The limitation of the stroke dataset is that the first one, it didn't capture the number of recurrent stroke, just only the new cases of stroke. And the mortality data was recorded in yearly format, thus we couldn't evaluate the impact of COVID clearly. Finally, we also working on some of the resilience factors for COVID pandemic using a district level data set. One of our promising factor that we found is the rural and urban gradient defined, and which we have two definitions for it. The first one, which is the population quintile, which means that in the district which have the lowest number of the population is defined as the most rural. And for the hospital level, it means that in the district with the second or tertiary care hospital defined as the most urban area, vice versa. From these two definitions that we define, we see that both outpatient and inpatient visit decrease more in urban area after the COVID pandemic, but there is a mixed result on the number of newly diabetes, hypertension, and stroke diagnosis, which from the first definition that we use population quintile, we didn't see any differences across the rural and urban gradient across district. However, the district with secondary and tertiary care hospital had lower diabetes, hypertensive, and stroke diagnosis. This may indicate that patients tend to visit hospital in their hometown instead of traveling to higher level hospital after the COVID pandemic. However, we need to further explore on the referral care usage and related policies before we conclude that these changes is because the patient behavior or the limitation due to the referral care. We would like to thank you, Professor Karen Eggerson and Sandra Kong, for helping us framing ideas, giving valuable comments, and preparing slides and organizing this webinar, and our Health Data Center, Ministry of Public Health, for providing data. Further analysis will focus on adjusting the models and adding other resilience factors and explore the scope beyond not just non-communicable disease, but to other disease and injuries. And lastly, now we are working on the individual level data set to provide more insight about the impact of COVID on both diabetes and hypertension, health utilization, and outcome. Thank you.
Thank you so much for all of our speakers. Before we go to Q&A, I don't know if any of our speakers wanted to add any clarification or address any questions. And those listening to the webinar, if you would like to type any questions in Q&A, please feel free to do so as I discuss with our panelists today. So thank you again, each of you. We know that addressing the pandemic and those who are vulnerable during the pandemic involves many different policies that you've discussed in the context of each of your health systems. It's part of an ongoing research collaboration. We hope to be able to provide more evidence for policy. I don't know if you would like to share at this moment with any of our speakers or those who will watch the recording later, what you see as the most challenging and the longer term effects that might inspire not only resiliency in the current pandemic moment, but building back better afterwards, how we can learn going forward, public and private sector and communities as a whole, to try to protect the vulnerable and better prevent and control chronic disease. With that very general question, maybe I'll go back through our panelists, starting with Professor Tandon.
So I think what has really happened during the pandemic was that there was a need for a very quick response, and that initially was primarily directed towards public healthcare facilities because they're directly into governmental control, and then with initiation of certain sort of change in regulations and the imposition of what is called the Disaster Management Act, the same could then be extended to private healthcare facilities. In India, about 70% of patients actually visit private healthcare facilities, and therefore there was a requirement for systematically co-opting the private healthcare facilities for COVID management. And there's obviously a bit of initial tension as to what was permissible, what was not permissible, whether a certain proportion of inpatient facilities needed to be set aside for COVID, how that segregation will take place, what is the sort of fee capping which would be necessitated so that private healthcare facilities, especially the higher end ones, could become more accessible to more proportion of the public than would have otherwise been available. capping on procedures, capping on investigations, making the process for getting a COVID test done, again, deciding on a fee structure for that. All of this became very, very important. And I think we learned along the way. This is something which necessitated a fairly rapid response. And I must say the central government really came in fairly quickly. We're a large country which has a federal structure. So what happens in a central government will take a little time for it to get selectively implemented across the country, because different states have a different structure. But notwithstanding those limitations, I think there was a fairly rapid response. And as you can see with the lockdown in the beginning, what really happened was that allowed some more preparedness to come into the health system to make it in a better position to accommodate the anticipated surge in cases later on. So we never really had in the beginning, as reported in some parts of Europe and the US, that there was an inundation of healthcare facilities, and that possibly that initial lockdown have managed to help out with that. And the second issue was the telemedicine practice guidelines. I realize that we haven't been able to go in much detail in seeing the effect, but clearly creating a systematic framework, I think, will hold us in good stead, especially for routine chronic care, and reduce the burden on in-person visits to the hospital. So I think these are the two really important areas which have emerged from this from the response.
Thank you so much, Professor Tandon. Dr. Kavita Singh, would you like to add anything?
Nothing much to add to what Professor Tandon has already described quite well about the Indian health system. Just from the patient perspective, thinking about the role of public and private hospitals in India, although the private hospitals are perceived to provide a high quality care, but cost of treatment is an issue for most patients. And during this pandemic and during the lockdown period, most patients were afraid to visit the hospital, and more so the private hospitals, with the fear of getting false positive result and the associated costs and the anxiety and fear attached to it. But as rightly said by Professor Tandon, that we need to strike a balance, and private hospitals are supporting during the period when we had high caseload of COVID-19 in India.
Thank you so much, Dr. Singh. Professor Yan, I don't know if you wanted to say anything on that question?
Yeah, just based on my limited understanding of your question, I'll share a few quick comments from the China experience in particular. First point is that it is so clear that we need a healthcare system and even a societal response that needs to be resilient. I like the word that you used. This came out in many discussions. So we need a resilient healthcare system and a resilient societal response to pandemic, and to deal with the wide range of consequences from the pandemic to the whole healthcare system, to the economy and the globe. And the second point is that in China, the effort to contain the pandemic has been largely led by the government, and this is fitting for our system. And I often hear comments that it may not be easy to learn or copy what we have to other countries. And this government-led effort is also supported by a culture that places emphasis on health and on collectivism, which means that we're willing to sacrifice to have some personal sacrifice for collective gain, and this is in the cultural gene. And then the third comment is that even though China has this government-led effort, but it is very clear to us, but maybe not clear to those outside of China, that the success actually came from shared responsibilities. I alluded to how the citizens acted in a way that is responsible and beneficial for the pandemic control, but also there are a large number of sectors, including private sectors, contributed to this effort. And in terms of the control at the grassroots level, it's not just the CDC, it's not just the community healthcare center, but a lot of government units and the social workers and volunteers all contributed to it. So the last comment is that when you say private, I understood that can mean private providers in the within the healthcare system. In China, this is still a growing portion. The government has putting a lot of emphasis on healthcare reform to promote the private providers and facilities, but it has met with only limited success. So we have a lot more to do. And also in general, to deal with pandemic preparedness in the future, as well as the large burden from NCDs, for example, we really need the whole of government and whole of society approach, which included private sector's role, that we need to study more.
Thank you so much, Professor Yan. Professor Chen, would you like to say anything about Hong Kong?
I think in the interest of time, just won't add very much. But yes, I think most of that similar, what we've just heard about China, it also applies in Hong Kong. And again, I think partly, I guess, it's culture as well. There is a desire to, share the burden, as it were, and comply with many of these kind of restrictions in order to get the case numbers down. But yes, there are many other effects that we're seeing on chronic disease from the lockdown itself and the access to care in Hong Kong.
Thank you. Dr. Kim, would you like to share any perspectives from Korea? You're on mute.
Yeah. Okay. Thank you. I think the outlook for the telehealth is important in future, and it was very striking that in USA, that much of the telehealth was in progress in this pandemic period. However, in Korea, the industry, from the industry point of view, there is a loser and there is a winner, and from the telehealth, and that dynamics is in consideration for the adaptation of the telehealth. And I think, but as I said, the progress we cannot resist very long for the progress of technology. And in particular, in primary care, telehealth can be an important tool for the future medicine. Thank you very much.
Thank you very much, Dr. Kim. Before turning to our Thai team for the final words, there's a question for Professor Tandon, who I know has to leave soon, in the Q&A. So if, Dr. Tandon, you have a moment, there's a question: could I ask about your view on how telemedicine service can be adapted to cater to India's predominantly rural population, where digital internet penetration remains low? Your thoughts on that?
I think that's a fair question. I think there are two, sort of, as a preamble, let me first say that the opportunity for a direct patient to care provider telemedicine in rural services and in rural areas may not be that easy compared to urban areas. But the model which is being considered is that rural participants who visit government health centers, there is a feasibility of the government doctor or the government nurse entering into a teleconsultation with a higher level healthcare facility on behalf of the patient, and therefore serve as a mediator for that response. So essentially, if I'm the patient, I go to a primary health center or a sub-center. During my in-person visit there can be a real-time interaction via telemedicine to a doctor at a higher level health facility, who can then assist the local healthcare provider to deliver care. And most of these government health facilities, even in rural areas, have access to the internet, and therefore that'll take care of some of the problems which have been raised in the question about the individual patient not having easy access to the internet.
Thank you very much. In our final few minutes, Professor Piya and our Thai team, would you like to add any final words?
Yes, I think this is a good question. And in Thailand, even though we have a majority, about 80% of care provided by public sector, the question about private sector is interesting in a sense that normally rich people who choose to pay by themselves, don't use the service, would go to private care. And in many cases, they actually adapt quite a bit in terms of using telemed, teleconsult. I have a friend who's in Bangkok in one of the big hospitals who take care of patients in Dubai or some other country. But those are not the majority of the cases. And in the public system, what we are concerning is how do we adjust the service provision so that it can be more efficient and basically linkage between hospital care to primary care, like Professor Nikhil Tandon mentioned. We explore this model of integrated care by looking at separate pilot models that has been adopted using linkage of data, which we are trying to set up a new information system to allow the data of patient to be able to flow across different type of providers, which we find to be an important infrastructure. At the same time, we are trying to look at different way of payments in terms of value-based payment that will help with facilitating this kind of adjustment so that people who could go to primary care will be there more. And lastly, in terms of the initiation of self-care and community-based community care, that's in the National Health Reform Plan to try to basically increase the proportion of people who will be able to help take care of themselves, take care of their family and others. This is envisioned for the longer term impact of NCDs, especially. Yeah. Dr. Wasin may have more to add.
Thank you, Professor Piya. Actually, most of the questions were answered by Professor Piya, but I just would like to add just one aspect on the role of including private pharmacies, private pharmacy to dispense the chronic medication for the patient like hypertensive and diabetes patient who can control disease, so that the patient don't need to go to the hospital and we can decrease the congestion in the hospital with this intervention. Thank you very much, Professor Karen.
Thank you so much to all of our speakers. And in the future, we'll all be looking into the production and distribution and equitable dissemination of vaccines for the current pandemic and beyond. Look forward to some public-private collaboration in that and building resilient health systems. Thank you so much again to all of you who listened in today, or to our students who are taking finals who will listen to the recording. Thank you so much to all of our distinguished speakers. Really appreciate your being with us today. And thank you to our wonderful program coordinator, Lisa Lee. Hope you all stay safe and will join us for some of the webinars in January. Thank you all so much.